Good afternoon. Firstly, just a very quick thank you to Darnshire County, the Royal Society of Medicine, for kindly inviting me and asking me to come to talk to you today. What they've asked me to look at is this idea of hypermobility and whether or not it's an asset or a liability. And for those of you who have actually looked at the literature, this is something that receives a relatively decent amount of attention in the rheumatology press when it talks about whether or not this is something that we can actually endorse and utilize. But it's quite topical. Myself and Roger Warman had been talking very recently about the management of patients with hypermobility. So I was very pleased to spend a little bit of time going and looking into this as a topic. So what I'd like to cover today is just talk a little bit about what hypermobility is. I don't want to get too caught up in this. Again, if you've spent some time looking at the literature, you'll see there is a lot of discussion in the press about what criteria should be used. But really what I'd like to do for the purposes of today is to talk about the bigger topics that will be put out there in the press, evaluate them, and talk about whether or not they can have an impact on what we're trying to advocate. Then I'll return to the question at hand, is whether or not this is a liability or an asset. And I suppose if you have a look at the next topic, you'll see which way we're going to start to lean with this. Because we'll talk about trying to turn a liability into an asset. When I looked at this part of the talk, I was reflecting on two conversations that I'd had quite recently. One was with a professor of surgery, and we were talking about levels of evidence. And he was saying that unless we can see level 1 or level 2 evidence, we really don't have much to take our practice forward with. And then a further conversation that I had with somebody about level 3 evidence, and if we're getting good statistical outcomes, we should really be shouting out about this and trying to get people to take this on as part of their practice. So when I looked at whether or not we can turn this liability into an asset, I wanted to look at the level of evidence that we have around that. But as always, I wanted to look elsewhere. So I've started to go into some of the other literature as well. And so we'll start to talk a bit about what evidence is around mechanical instability and see whether or not we can create an evidence-based medicine approach for interventions for these particular groups of athletes based on the building of evidence from other areas. And in particular, we'll start to explore and look at the value that neuromuscular training is offering us in other areas. Because the thing that I'd like to do towards the end of it is to get to a point where we can make a conclusion other than we need more research. I don't know about you, but I'm getting pretty tired of reading research papers that said we just need to do more research. The world that I work in, I'm accountable. So when my patients sit in there and I say to them, I'll get back to you in a couple of years when somebody else comes up with another paper, it doesn't really help me. So that's what I want us to be able to do, is to say, let's just put it out there and say, let's start to move forward with this. And I'll talk about the process that we'll use for that. So first of all, again, it said, if you've looked at the literature, you'll see there's a huge amount of definitions that are used in there. But if we were to break them down into two very, very broad groups, we'll talk about generalized joint hypermobility, which is an acquired condition where we have a range of movement beyond what we'd expect to be the normal physiological limits. Now, as I said, I don't really want to get too caught up in the actual criteria that are used, but what are normal physiological limits when it pertains to sport? Because when we do all our other physiological testing, when we talk about VO2 max testing, when we talk about isokinetic testing, we talk about max torque scores, we expect our athletes to have far greater ranges, yet we're doing a comparison here to normal. In the second group, we're starting to look at the benign hypermobility joint syndromes. And again, this is the genetic disorders where we see the sort of matrix of proteins affected in the connective tissue. So those are the things that will be referenced in the literature. And I will move around a little bit between them, but I've tried to keep it as tight as possible to those definitions so we understand what it is that we're talking about. So in context to what I tend to see most of, what I wanted to do was to start off looking at some of the more recent articles, but particularly starting to look at the articles that pertain to musculoskeletal pain and dysfunction, because that's the nature of the practice that I work with. So this is one of the first papers that I actually looked at, which was by Atkins, and there was a positive correlation in a relatively decent powered study of 184 subjects with, a good correlation then between benign hypermobility joint syndrome and lumbar disc herniation. If you looked at the study by Buchanan, you can actually see that, again, in a match control study, although there's a very small sample size, we're looking at an increase in postural differences noted in their control group versus their test group. And what was interesting for me is they're starting to look at the areas of most problems and most concerns coming through as the knee. This was quite a big study by Cameron in military recruits, a well-powered study looking at military recruits and looking at the relationship between generalized joint hypermobility and the history of glenohumeral joint instability. And if you take that study and keep with the shoulders and you look at Mohammed's work, actually that's quite a worrying statistic, because in the hypermobile patients, the higher incidence of recurrent shoulder dislocations, for me, comes out quite considerably higher than the non-hypermobile group. So we're starting to see a building of evidence towards some of the challenges that working with these patient groups might bring us. And Falkeslev's recent study just looked at very simply in another match control group, albeit with slightly smaller subject numbers, the decrease in generalized trunk stability in gait and imbalance positions. But I think the next paper was one that took me by surprise, and not something that I'd actually come across in my readings previous to that, is actually looking at the risk of bone mineral density. And considering the population groups that I work with and the emphasis that we put on bone mineral density, this is not something that I certainly considered. I'm afraid this is a very small group that we're looking at, but I think it's something worth sitting up and actually taking notice of if you're involved with population groups that will include hypermobile and generalized hypermobile patients. ACLs is one of those areas that have received a huge amount of attention in the literature, and certainly if you looked at this, and again, it's a decent powered study where we're looking at patients with ACL injury and having quite a significant odds ratio there of those who have joint hypermobility to actually having ACL problems. But if you look at Sahin's work afterwards, then you'll see that actually the decrease in extensor muscle strength in hypermobile patients in another match-controlled study might give us some of those indications as to why we see more risk of ACLs in hypermobile patients. But again, when I looked at that paper and looking at what we'd learned from Buchanan in the early literature, is actually these patients experience a fair degree of pain, and that pain may be centered around their knees. So the pain-modulated response might also be one of the reasons as to why we're seeing an increased risk within this particular patient group. And similarly, another study by Sahin looked at the significant reduction in proprioception in a hypermobile patient group compared to their matched controls. So a very quick snapshot over some of the more recent stuff that's been published in regards to identified and single pathologies within the literature. But then what I wanted to understand was, is this something that then translates into various sporting environments? Does it have an impact, or is this just something that gets managed along the way? So I started off looking actually outside of maybe where we'd expect to find hypermobile patients. So an interesting study by Stewart back in 2004 looked at an increased incidence with hypermobile patients and 116 injuries per 1,000 hours versus their non-hypermobile of 43 per 1,000 hours. I think it's quite a big difference. And similarly, a good friend of mine, Lisa Kelly, along with Zoe Hudson, looked at some of the elite junior hockey players, field hockey players in the UK. And again, they had a statistically significant increase in injuries amongst their hypermobile group. And again, we've got similar work coming from the netball side with Smith, where they've seen another significant association between the prevalence of injury and hypermobility. So it's not just necessarily the activities and the sports that we would associate having maybe a higher prevalence of hypermobile patients in them, but actually some of the other sports is a critical component and something we do need to consider. If we move into dance, Ali and Catherine's work back in 2012 showed there wasn't a correlation between generalized joint hypermobility, but there certainly was when you looked at joint hypermobility syndromes, and they've used the Brighton criteria for their work. And similarly, if you look at Janet Briggs's work with Ballet, again, there is a significant difference in injury between joint hypermobility syndromes and non-joint hypermobility syndromes. And this also then translates all into dance theatre as well. So overall, we're starting to see that not only are this particular patient group more at risk maybe of injuries and instabilities, but actually it translates into the activities that they go and undertake as well. So if we return back to our original question and decide whether or not this is a liability or is it an asset, there was an interesting paper by Bezo-Velasco back in 2013, and I think it's a nice one just to highlight maybe where that balance of power is. So on the asset side, we've got increased range of movement. The liability side is pretty heavily stacked against. And we talked about some of the musculoskeletal injury and pain sides, but carpal tunnel syndrome, we're looking at epicondylitis, we're looking at TMJ problems. And actually, if you go further down the list on the right-hand side, you start to realize that there's actually quite a considerable amount of medical management that needs to be considered when you're looking at this sort of patient group. So I'm going to leave it up to you to make up your own mind as to whether or not you consider this to be a liability or an asset. I certainly know which way I sit on it. But we can't be defeatist, because we're going to have to deal with this patient group anyway. I spoke at a conference at the British Society of Rheumatology a few years ago, and one of the rheumatologists asked me whether or not I regularly screen for hypermobility. And my answer was I don't. And when I put this part of the talk together, I thought, well, should I? Should I be actually looking at this? And so what is the evidence base? What is the support for me changing my practice by doing these screenings to undertake so I've got some more specific, detailed intervention for this particular population group? Well, I did struggle when I looked at the literature to find out what support I had for actually implementing a particular structure for this population group. So Shepard's paper talks about the enhanced physical fitness that could be beneficial, but its effectiveness remains unproven. Whereas Sahin's work, and again, this was a small match control group that they worked with, but noticed significant decreases in pain and increases in occupational activity through the use of proprioception exercises. Now, I don't know about you, but that strength of evidence, certainly from the hypermobile patients, for me wasn't very comprehensive, and probably not enough to change my answer to the rheumatologist over I'm really going to start screening for hypermobility because there's a great deal of evidence to suggest I need to manage them in a particular way. But we are working in an accountable world. So what I wanted to do was to see whether or not there's a possibility. Can we create solutions, and can we actually find some evidence to support that? Is there ways that we can sit with this patient group and say, do you know what? We can actually go forward with this with relative confidence and good evidence to support what we're doing. So I went back and I started to have a look at the definitions again. And obviously the definition we talked about for hypermobility is we talked about this movement beyond the physiological range. And then I looked at some of the definitions that are used for ankle pain and dysfunction, and particularly for mechanical instability. And it's the same definition. We're talking about movement beyond the physiological range. So what I wanted to do was to see whether or not we could start to learn something from some of the other literature out there, and can we use that to create and build some evidence for management of patients with hypermobility. So if you look through the literature, we've actually got some pretty good evidence for the management of ankles. We've got one Cochrane review, and we've got a number of systematic reviews, and they support, albeit with certain limitations of the studies that they were based on, but we've got good support for the use of neuromuscular training to both reduce the recurrence of ankle injuries and to improve proprioception. Now, if you think back to my little whistle top of some of the most recent literature, well, actually, I remember proprioception being highlighted a number of times as an issue with hypermobile patients. So we're starting to understand that there might be some level 1 evidence out there that we can lean on. If you take that neuromuscular training concept a little bit further and you have a look, there's a number of systematic reviews that show the support of neuromuscular training for things like sports injury prevention. Well, we saw a little bit of that being a problem in hypermobile patients. Lumbar region, again, something highlighted in our whistle-top literature review. Anterior cruciate ligaments, again, a problematic area for hypermobile patients. So we're starting to see that there is a possibility of starting to take evidence from another area, and could we import that for our hypermobile patients with confidence and support? The other thing I reflected was a paper that we published last year where we were able to demonstrate a significant reduction of injuries in a population of dancers using neuromuscular training. And just so it doesn't sound like I'm standing up here shouting about the research that we did, Shaw Bronner and Ruth Solomon have done some great work as well, reducing the injuries in dancers. But what I was reflecting on is a great piece of work done by Maura, who looked at the prevalence of hypermobile dancers within various groups of vocational schools and professional companies. And there's a high prevalence of them in the student population. But what I was interested in is we had 46% of the core and 27% of the soloists in professional company. So if we start to think about that and we try to build our evidence then for an effective management strategy for hypermobile patients, we go back to our paper that we did. Well, we've got some evidence now that says that we can implement a neuromuscular training program to reduce the impact of injuries in a population group that actually contains hypermobile patients. And we did this based on a neuromuscular training program, something called the hybrid intervention model, which I'll talk about. And we were able to get a significant reduction of injuries. So albeit slightly tenuous linking, we can start to think about how we can put a strategy in place to look after this particular population group. So rather than sitting here and saying, we need more research, we can start to say, well, let's move towards a recommendation. Let's actually start to think about how we can do this. So for those of you who did your Masters in Sports Medicine at Queen Mary's, I'm going to go on about this, which you've heard me talk about, so go grab a coffee for 5 minutes. Those of you who haven't, bear with me, because what we did with this program is we put together something called the hybrid intervention model. And we called it that because it was based on my experience, which is in a lot of professional Olympic sports and then with dance. And what we were trying to create is we looked at the performance attributes of our athletes. And those attributes are born out of incredible levels of skill, of fitness and strength, but arguably not the same level of skill that we see with our elite dancers, where our elite dancers have an incredible level of skill and efficiency of movement, but comparatively speaking, do not have the same physiological variables that we see with our athletes. And so what we were trying to do is create a continuum between our athlete and our dancer, and trying to individualize each person within that, saying that, do we need to make them more efficient, like a dancer? Do we need to make them more fit or strong, like an athlete? And picking somewhere between that continuum to actually bring in a very efficient movement pattern with the power and strength that we see with our dancers, with our athletes. And how we did this is we put this 3-stage training program together. So every single training program from start to finish will have these 3 fundamental components in it. The first stage is neuromuscular firing patterns. Neuromuscular firing patterns, for me, were the foundation for where we're going to be able to get loading. Until we had that solid foundation, if you try to put extensive loading on that, you run the risk of injury and you create an inefficient movement pattern. We talked about segmental deficit, where we're trying to look at any area within the whole kinetic chain that's not doing its fair share of the work, isolating, identifying, and targeting that muscle group, and then finally looking at functional integration. I felt very strongly that it was very important that we reinforce the motor patterns so that whatever training we were doing was building up towards what they were going to be required to do, whether it be on stage, on pitch, in studios, whatever their requirements were. Now, the relative ratios of these components of their training program alter depending on where they are within an injury episode or within a deficit episode, if that's what's been identified with screening. So in an early stage where pain becomes quite a critical component of an injury episode, we notice that neuromuscular firing patterns are normally knocked out of sync. So we'll find that a large proportion or a large ratio of that program will be spent looking at neuromuscular firing patterns and kind of resetting that balance. We might have a very small component that looks at functional integration, but for us it was very important to have that feedback loop, and we still have functional integration, albeit that we're just mimicking some of the postural positions that they're going to be getting into when they get fully functional later on down the line. As we move through the injury episode, we might find at end stage that actually the functional integration is the greatest component of their day. And so what we're doing is a small amount of neuromuscular firing patterns, a little bit of segmental deficit training, and then we move to a much larger functional integration. And that's how the program worked, and that's how we implemented it for that study. So what I wanted to do was to think about that and think about some of the specifics that we've learned from the hypermobility literature and say, is there a way that we can shift and organize this program to address some of the specificity that we know with hypermobility? So in doing so, I started to look at the first stage of the program. And as I said, the neuromuscular firing patterns were really about creating a principle of efficiency of movement to reduce any unnecessary energy loss or compensation. This is the dancer side of that continuum. And when you think about hypermobility, this becomes quite an important concept, because if you're not a hypermobile person, you can relatively comfortably sit on your ligaments and create a degree of stability. Now, for all the ills that physios go on about ligaments and ligament problems, is they're energy efficient. But if you are not efficient in that, and you're having to use your muscle tissue to do the same job because you're hypermobile, muscle is not energy efficient. It uses a lot more energy to create the same amount of stability. So one of the challenges that we'll have with this group is we want to keep them as efficient as possible. So that concept feeds into how do we get that process of efficiency, how do we get them really movement efficient as part of this program? So that brings into the question of core stability. I know one of the questions by Gareth was, everybody knows about core stability. I would certainly challenge that, because if you ask people to define core stability, gosh, they'll come up with a million of different things that they'll say to you. I looked at some of the definitions, and certainly Wilson offered up a definition of this ability of the lumbar-pelvic complex to prevent buckling and return to equilibrium after perturbation. I quite like what Mark Comerford and Sarah Mottram have done, is delineate that a little bit further, and they talk about motor control stability. And with there, they've got the CNS modulation of efficient integration of low-threshold recruitment of local and global muscle systems. But what I like to focus myself is I like to talk about neuromuscular control. And this is where we talk about the unconscious efferent response to afferent signaling regarding dynamic joint stability. And why I like that is because it doesn't just pertain to the trunk itself. We're talking about dynamic joint stability across the whole kinetic chain, albeit ankle, knee, hip, back. It doesn't really matter where it is. because what we're looking to do is to integrate all of these definitions and find an efficient movement system that prevents any unnecessary buckling, prevents an unnecessary energy loss in a patient group that cannot afford to use excess energy just to provide stability. So then we move on to the next stage, which is our segmental deficit. And the challenge that we always had with our segmental deficit is we used to look through the kinetic chain and try to find any particular muscle groups that were either insufficient, or call it weak for want of a better term, and target them with individual identified exercise programs. And so looking at what we've learned about hypermobility, what we need to think about is how we're going to get an element of strength endurance into them, because that's what they're going to require. They are going to require the ability to have stamina within their muscle groups in order to sustain it. So we're starting to move towards the high reps, high sets, small recovery rates. We're talking about fitness for muscles, but targeted muscle groups. So if you look at some of the evidence around that, Jensen did some interesting work where, with very simple 4-week strength programs, was able to improve maximal, dynamic, and isometric strength. Now, I like the idea of optimizing isometric muscle strength, particularly in a group that we're talking about trying to stabilize and provide support. So that fills me with some confidence. Their research was also able to show that we could get a 4-week skill training improvement. So knowing that we've got a population group that is going to be required to be efficient as possible, if we can improve their motor skills, that's an imperative part of our management program for them. Because we know we need combined strength and motor skills for athletic performance. But in a population group that is going to be required to be as energy efficient as possible, if we can enhance that motor skill capacity alongside some isometric strengthening, well, we can actually provide a lot more support for them. So again, Atkins' research, I think, was very interesting in that their study will show that we were able to acquire this skilled movement, and which creates this reorganization of the neural circuitry within motor cortex, supports the production of the refinement of skilled motor movements. We saw increases in strength that could be mediated by an increased capacity for activation and recruitment of the spinal motor neurons, and increased metabolic demands associated with the endurance training due to cortical angiogenesis. But I think the critical thing out of all of that is that we can actually induce and improve motor patterns with strength and endurance training. So if we use that concept within our segmental deficit, we have the capacity of providing motor skill training and strength endurance for muscle groups in a patient that's going to require those in an energy efficient way to support them and hopefully prevent some of the injuries that we were talking about earlier on. Then the final stage of this program, we looked at functional integration. And as I said, we do this from onset. We do it very, very early on, albeit in a smaller guise when we're doing early onset injury, and then much, much larger as we get to end stage. But what was very important is that we started to replicate the functional needs of whether or not they be a dancer or an athlete to reinforce those motor patterns. But our research showed us that dancers are required to do anything from 31 to 35 hours of dance-related activity a week, 6 hours of rehearsals in a day. So if we're trying to prepare this particular patient group to take on the rigors and the demands of that sort of work, we need to make sure that we build that into our functional integration component. So we're starting to draw out their programs based on this principle of trying to keep them efficient with their movement patterns, but improve their strength endurance so they can actually support their systems and try to improve the stability around the area to reduce the risk of injury. So really, in conclusion, what we're looking at is we've got quite a considerable amount of evidence that certainly hypermobility can be more of a liability than it can be an asset. I'm afraid there's also a lack of evidence from the hypermobility literature in particular about the effectiveness of interventions. That said, we do have level 1 evidence for the effectiveness of neuromuscular training programs in conditions that are very similar, where we've got increased range of movement beyond the physiological range. We've also got some level 3 evidence based on work that includes hypermobile patient groups, that neuromuscular training programs can benefit and statistically reduce the impact of injury in these population groups. So what we can do is we can start to bring all that information together. One of the things that you may or may not be familiar with is the grade system. The grade system is just an evaluation tool, has a very transparent framework of evaluating the strength of evidence, but in particular allows us to go and make a recommendation. And the recommendations are based on patient important outcomes. But one of the things I like about the grade system is it uses the phrase, in the absence of stronger evidence. Now, I'm very conscious of the fact that I've drawn a very tenuous link of evidence between what we've got for managing hypermobile patients and getting to an end-stage recommendation. But what I would say, in the absence of stronger evidence, I would look at a recommendation of using neuromuscular training programs like our hybrid intervention model with certain adaptations for the management of hypermobile patients, rather than waiting for the next piece of literature to come out there and say, we just need some more evidence. Thank you.